Hello, I'm Dr. Vandenplas, and it's my pleasure to present you this webinar on allergy, focusing on non-Ige mediated cow's milk allergy and or functional gastrointestinal disorders. This slide illustrates the layout of my presentation, and of course, the main part of the presentation will be on the management. But before anything about cow's milk allergy, it is obvious that breastfeeding should be stimulated as much as possible because breastfeeding is an unequaled way of providing the ideal food for the healthy growth and development of infants. What's the definition of functional gastrointestinal disorders? Functional gastrointestinal disorder is defined as after appropriate medical evaluation, the symptoms cannot be attributed to another medical condition than a functional disorder. In other words, organic disease has to be excluded. And a functional gastrointestinal disorder can coexist with other medical conditions that themselves result in gastrointestinal symptoms. And cow's milk protein allergy is a perfect example of that. But it is not because the child does suffer cow's milk allergy that the child is protected to also have a functional gastrointestinal disorder. What is the definition of cow's milk allergy? Well, cow's milk allergy is a reproducible clinical abnormal reaction to cow's milk protein due to the interaction between one or more milk proteins and one or more immune mechanisms. However, in daily practice, the only immune mechanism that is easy to demonstrate is IgE-mediated allergy. But we all agree that there is also non-Ige mediated allergy. And then it's the question, how can you demonstrate the involvement of immune mechanisms? It's virtually impossible in daily routine. What are the symptoms of non-Ige mediated allergy? The mild to moderated IgE-mediated cow's milk allergy, as here illustrated in this algorithm from the United Kingdom, are easy to recognize. And the severe IgE-mediated symptoms are also easy to recognize. But the mild to moderate non-IgE-mediated cow's milk allergy symptoms, as illustrated on the left part of this study, of this slide, is not so easy to recognize. Mild to moderate non-IgE-mediated cow's milk allergy is mostly occurring 2 to 72 hours after the ingestion of cow's milk protein. And the formula fed, exclusively bread fed, or onset of mixed feeding. Usually there are several of the different symptoms which are present. Gastrointestinal, skin, and respiratory and general manifestations. And children with gastrointestinal manifestations of cow's milk allergy are more likely to have a non-Ige mediated mechanism. So adverse reactions of food can be divided in immune-mediated reactions and non-immune-mediated reactions. The non-immune-mediated are metabolic or other reactions. And the immune-mediated reactions are IgE-mediated or non-IgE-mediated, or mixed IgE and non-IgE, and also cell-mediated reactions do exist. But the question is there in fact a difference between adverse reaction to cow's milk protein, hypersensitivity reactions, non-IgE mediated reactions, or functional gastrointestinal disorders? How to demonstrate the difference in daily clinical practice? What do we know about the incidence of these different conditions? Well, according to these data from France, 80% of the clinical visits in early life are due to gastrointestinal discomfort. And that's such as regurgitation, constipation, crying, and other manifestations. How frequent does regurgitation occur? Well, according to a review of the literature, it's about 25% of the parents which have complaints which go to seek medical help because of troublesome regurgitation. So that's 1 in 4, which is extremely frequent. The same incidence is reported for infantile colic. The median is 18%, and the percentile 75 is 21%. So infantile colic occurs in about 20% of all the infants. And that's confirmed by these data from North America showing that in infants 3 to 4 weeks of age or 5 to 6 weeks of age, the incidence of infantile colic is between 20 and 25%. So extremely frequent. And constipation is slightly less frequent, but it's about 10% of all the infants which suffer infant constipation. And whenever we discuss functional gastrointestinal disorders, we discuss them separately. But in fact, in daily practice, they often occur combined. This slide illustrates the incidence of different functional gastrointestinal disorders in infants with colic in dark gray or in infants without colic in light gray at the age of 4 weeks or at the age of 8 weeks. And you see that all the different functional gastrointestinal disorders are 2 to 5 times higher in infants with colic than in infants without colic. So having colic makes the child at higher risk to develop other functional gastrointestinal disorders. But we do not need colic. According to these data from France, in over 2,500 infants, the vast majority of infants present with a combination of functional gastrointestinal disorders, 77.8%. So 3 infants in 4 present with at least 2 functional gastrointestinal disorders combined, 63% with 2 and about 15% with 3 functional gastrointestinal disorders. So most of the time, infants with a functional gastrointestinal disorder present with a combination of different functional disorders. And what about allergy? Well, we know that parents need to be reassured because their perception is always much worse than daily reality. And that's true for allergy, but that's also true for the functional gastrointestinal disorders. Incidence of cow's milk protein allergy has been reported in breastfed infants, but is very rare. It's less than 0.5%. And in formula-fed infants, the incidence of cow's milk allergy is, according to literature, majority of literature, between 2 and 7%. And today we accept most of the time an incidence of 3 to 4%. However, the discrepancy between perceived cow's milk protein allergy and proven by a double-blind placebo-controlled food challenge is huge. So the prevalence of food allergy and intolerance in the adult Dutch population, according to Perception, reported some 20 years ago, was 12%. So assuming that the food allergy, food intolerance is equal among participants, non-participants and dropout, the prevalence of food allergy in the Dutch adult population is estimated to be 2.4%, while the reported prevalence according to the individuals themselves is over 10%. Another study looking at food intolerance and double-blind placebo-controlled food challenge. So 20% of a nationwide sample and 20% of the high-Y combi sample complained of food intolerance. And of these, 93 subjects entered a double-blind placebo-controlled food challenge. And the estimated prevalence of reactions to the 8 foods tested in the population varied between 1.4 and 1.8%, according to the definition used. But so again, a huge discrepancy between perception and reality. Adverse reactions to food were reported in 14% in this study from 2006. About incidence of parentally reported and clinically diagnosed food hypersensitivity in the first year of life. But between 6 and 9 months and 9 and 12 months, it's only 1.4 and 2.8% of the infants which were diagnosed with food hypersensitivity on the basis of open food challenges, and 0.9 and 2.5% on the basis of double-blind placebo-controlled food challenge, which results in an incidence of maximum less than 2.8%, while the perceived prevalence was about 15%. And these are data from the Rejuvenation study, looking at the incidence of cow's milk allergy in different regions in Europe. So the overall incidence of challenge-proven cow's milk allergy was not higher than 0.5%, with differences in different regions of Europe. So according to the region, the incidence seemed to different. But of all the children with cow's milk allergy, 23.6%, so 25%, had no cow's milk specific IgE in the serum. So according to these data, non-Ige mediated allergy occurs in 25% of the population. And of the children with cow's milk allergy who were re-evaluated 1 year after the diagnosis, 70% tolerated cow's milk, including all children with non-Ige associated cow's milk allergy, and 57% of those with Ige associated cow's milk allergy. But that means that infants with non-Ige mediated cow's milk allergy develop tolerance in the vast majority, according to the Rejuvenation study, 100% before the age of 1 year. And functional gastrointestinal disorders, colic and retargetation, disappear also before the age of 1 year. Colic before 5 months and reflux mainly before the age of 1 year. It's true that infant constipation tends to continue beyond the age of 1 year. So I said already that infants presenting with functional gastrointestinal disorders present most of the time with a combination of symptoms. And what about allergy? Well, if we look at the incidence of different organ systems involved in cow's milk allergy, it's 60% of the infants which have gastrointestinal symptoms, 30% with respiratory symptoms, and 70% with skin manifestations. And general manifestations occur in 50%. If you summarize this, you end up with 200%, which means that the vast majority of infants presenting with cow's milk allergy present with a combination of different symptoms, not different from the functional gastrointestinal disorders. And that's illustrated also in these data of 1,000 patients, where it said that 55% present with atopic skin manifestations and gastrointestinal symptoms, 22% with only gastrointestinal symptoms, 5% with acute IgE, atopic and gastrointestinal symptoms, 4% with atopic and gastrointestinal symptoms and failure to thrive, 3% with gastrointestinal symptoms, and failure to thrive. So 90% presents with a combination of symptoms. So it's not easy to diagnose functional gastrointestinal disorders versus non-Ige mediated cow's milk allergy based on the combination of symptoms. Can the challenge test help us? The challenge test, open or blind, is considered to help to differentiate between functional gastrointestinal disorders and non-IgA mediated allergy. Is this possible? Management of functional gastrointestinal disorders and non-Ige mediated cow's milk allergy. Well, according to the guidelines for the management of cow's milk allergy from Australia, from the European Society of Pediatric Gastroenterology, Hepatology and Nutrition, and from the World Allergy Organization in the DRACMA guidelines, extensive hydrolysate formula are recommended as the first choice in almost all situations of cow's milk protein allergy, except for eosinophilic esophagitis, where amino acid-based formula is recommended, and for Heiner syndrome. Now, what about the management of regurgitation and reflux? Of course, thickened feedings are the first therapeutic option in formula-fed infants that regurgitate a lot. But what about hydrolysates? What has been shown is that hydrolysates have a much more rapid gastric emptying than intact protein, and the gastric emptying of whey hydrolysate is the same as the gastric emptying of human milk. And the gastric emptying of whole cow's milk, for instance, is much slower. And of course, if you want to treat infantile regurgitation, one way how to do it is to thicken the formula. Another way how to do it is to empty the stomach. So hydrolysates improve gastric emptying. So if there is a decrease of infant reflux, infant regurgitation on a hydrolysate, is that really a proof that allergy was the cause? Because the difference might as well be caused by a difference in gastric emptying. So what's the effect of hydrolysate on gastric emptying? There are not much data in children. These are data in 9 overweight and obese adults. And gastric emptying of the casein hydrolysate compared to intact casein was not different in those obese adults. More data on gastric emptying, but again in adults, 6 healthy adults, a very small group. The rates of intestinal absorption of water and amino acids was similar with the exception of the casein protein solution, which was slower. And the rate of gastric emptying is independent of the degree of protein fractionization. So again, no difference in gastric emptying between hydrolysate and intact protein in adults. In preterms, regurgitation and vomiting were observed in 78 versus 64% of newborns after standard or hydrolyzed formula. The difference was statistically non-significant, but so there was a trend towards less episodes of regurgitation and vomiting with the hydrolysate. And no difference were found in gastric emptying time. And gastric emptying occurs as a function of caloric density. So, role of caloric density on gastric emptying might be of major importance. The gastric emptying of a casein predominant soy and whey hydrolysate formulas were not significantly different in this older study. A significant difference was observed on gastric emptying between casein predominant and whey hydrolysate feeding. So again, suggesting that hydrolysate, which most of the time are either whey or casein hydrolysates compared to intact protein, which most of the time is a mixture of whey and casein in infant formula, these data suggest that the gastric emptying of the hydrolysate is faster. These data from in Italy, from Flavia Indrio, suggest that the effect of a partially hydrolyzed whey infant formula supplemented with starch and a probiotic on regurgitation and gastric motility is significant. And whether that is due to the probiotic or the hydrolysate is not very clear, but it's clear that in the group that was fed with the probiotic and the hydrolysate, gastric emptying was much faster. Higher feeding volumes are also associated with faster gastric emptying and longer gastric emptying times. So a longer gastric emptying time was associated with higher adenopectin concentrations and lower casein-whey ratio. So gastric emptying time is associated with casein-whey ratio. And breast milk has a faster gastric emptying than formula milk. Now, what's the impact on reflux and cow's milk allergy and thickened formula or extensive hydrolysate? We try to look at this in infants suspected of cow's milk allergy and who were vomiting a lot. And we evaluated those infants using a score. And all those infants had a challenge test. And so they were divided in a group which was considered cow's milk protein allergy positive, those with a positive challenge test, and cow's milk protein allergy negative. And they were fed either a thickened extensive casein hydrolysate or a non-thickened extensive casein hydrolysate. And these data showed you that if the challenge test is positive and if the child does have cow's milk protein allergy, that the improvement of infant regurgitation and reflux, whether the extensive hydrolysate is thickened or non-thickened, does not really matter. It's the hydrolysate which is the effective treatment. And you do not have to treat that infant with cow's milk allergy with a thickened extensive hydrolysate. However, in the group with cow's milk protein allergy negative, those with a negative challenge test, the thickened extensive casein hydrolysate was effective in decreasing the episodes of infant regurgitation and was much more effective than the non-thickened extensive casein hydrolysate, although there was also a significant reduction of the reflux symptoms in the group treated with the non-thickened extensive hydrolysate, which had a negative challenge test. And that's because of the gastric emptying of the casein hydrolysate, which is faster than that of the intact protein. But so if cow's milk protein allergy was negative, if the challenge test was negative, the thickened formula was more effective than the non-thickened casein hydrolysate. While if the challenge test is positive, it does not matter if your hydrolysate is thickened or not. This means that in daily practice for infants where you cannot separate whether they are in fact suffering from a functional gastrointestinal disorder or cow's milk allergy with a thickened extensive hydrolysate, you treat both conditions. So the child will go better, but you do not know if you treated reflux or if you treated cow's milk allergy. So what is the newest algorithm that we propose? Whenever you see a child that is presented by the parents because of severe reflux, regurgitation, and vomiting, look for alarm symptoms. If they are present, refer the child appropriately. The next step is Look for signs and symptoms of cow's milk allergy and look at the same time for feeding position and interaction with parents and the baby. And anyway, try to manage feeding position and interaction during at least 1 week. Avoid overfeeding. And if there are symptoms and signs of cow's milk allergy, treat a child with an extensive hydrolysate and see if there is improvement or not. And with this algorithm, you will manage both functional gastrointestinal disorder and cow's milk allergy presenting as frequent reflux. What about crying? Well, this is a study in infantile colic with a partial whey hydrolysate, high beta palmitate, and prebiotics, showing a significant reduction in the treated group and also a reduction of the crying time in the control group, illustrating the importance of reassurance and the natural evolution towards decrease of the infantile crying. But this therapeutic formula with prebiotics, beta palmitate, and a partial whey hydrolysate and reduced lactose resulted in a significant improvement of infantile colic compared to the control group. And there is also evidence that extensive casein hydrolysates can be effective in the management of infantile colic. Same from this systematic review that colic may improve with a hydrolyzed protein formula. And this meta-analysis, which was performed by someone from your country, Pedro Gutierrez Castrellon, showed that in infants which are formula fed, dietetic interventions are much more effective than drug interventions for infantile colic or any other interventions. The efficacy of Lactobacillus reuteri was especially shown in breastfed infants. So probiotics to prevent infantile colic. According to this Cochrane review, there was no efficacy of the probiotics on colic, but there was a significant decrease of daily crying time, which was induced by the probiotic. So how should you manage infantile colic? Look again for the warning signs. If they are present, refer and test accordingly. Most of the time, they will not be present. Look then at the second step for other symptoms of allergy, for non-infective respiratory symptoms, atopic dermatitis, regurgitation, diarrhea, constipation, so gastrointestinal symptoms, and consider also a family history of atopy. If these are present and positive and you suspect cow's milk allergy, then treat the child accordingly with an extensive hydrolysate and see if there is an improvement or not. If those symptoms of allergy are absent, look for other parental warning signs which are frequently present: anxiety, depression, child-mother interaction, etc. If that is a risk factor, do not hesitate to hospitalize the child for observation. If that's absent, then avoid overfeeding and overstimulation. Consider probiotic in the breastfed babies and consider partial hydrolysate versus extensive hydrolysate, reduced lactose, prebiotics or probiotics in the group which is formula fed. What about constipation? Well, hydrolysates result in a higher higher defecation frequency than intact protein. So protein hydrolysates bring defecation frequency closer to that frequency of breastfed infants than intact protein. Studies have reported that cow's milk protein-free diet has a beneficial effect on constipation with a rate of successful outcome between 28 and 78%. And that's also illustrated in this slide, where cow's milk-free diet as a therapeutic option in childhood chronic constipation. And you see that eliminating cow's milk really increases the bowel movement in a number of children. So how to manage constipation? Again, look for warning signs, and then allergy is among those warning signs. Refer and test appropriately. Consider if these are absent, then reassure and educate the parents, and consider a partial hydrolysate with prebiotic, probiotics, increased magnesium, beta palmitate, and palm oil-free formula. If there is sufficient improvement, you continue with your therapeutic intervention. If there is insufficient improvement, think again that allergy may be the cause of this infant constipation, and think about, among other possible interventions such as lactulose or polyethylene glycol, to switch to an extensive hydrolysate in case of suspicion of cow's milk protein allergy. That brings me to conclusion. Does it really matter whether it's allergy or a functional disorder? And how will we make the difference? Well, this paper from some 5 years ago put cow's milk allergy among the top level differential diagnosis in infants presenting with gastroesophageal reflux disease. In daily practice, it's very hard to make the difference between non-Ige mediated allergy causing reflux and functional gastrointestinal disorder causing reflux. And according to these data from 10 years ago, a diagnosis of cow's milk allergy was considered in up to 1/3 of the children with signs and symptoms of gastroesophageal reflux disease. The diagnosis of either cow's milk protein allergy or a functional abdominal pain disorder and distinction between them is challenging because of the non-specific and overlapping symptoms. Allergic proctocolitis is reported to be a risk factor for functional gastrointestinal disorders in children. So after adjustment for age and sex, the odds ratio for functional gastrointestinal disorders in allergic proctocolitis group was 4.39. So developing cow's milk allergy at an early age, non-IgE mediated cow's milk allergy at an early age, predisposes that infant to the development of functional gastrointestinal disorders later in life. Remember also the allergic march. Developing of cow's milk allergy early in life predisposes the child to develop more frequent allergic disorders later in life. This paper concludes that a common colic, gastroesophageal reflux, and constipation in infants under 6 months of age do not necessitate an allergy workup. Although the differential diagnosis is hard to make, but it's true that the allergy workup results of investigations will be frequently negative. Functional gastrointestinal disorders and cow's milk protein allergy can, of course, occur together just by coincidence because of the high prevalence. Regurgitation, as said, occurs in 25% of all the infants. Infantile colic in 20%, constipation in 10%, atopic dermatitis in 20%, respiratory tract infections in infants under the age of 1 year, certainly in more than 50%. So it's also relatively frequent just by coincidence that you can have a combination of those different manifestations. So how should we manage that as a healthcare professional? Whenever we see an infant with a functional gastrointestinal disorder or an infant suspected of cow's milk allergy, we should always educate and reassure the parents, and then use an appropriate nutritional treatment to bring a solution to improve the quality of life of the infant, of the family, in order to manage the symptoms. Because with that appropriate dietary treatment, whether it's for a functional disorder or for cow's milk allergy, the infant will become symptom-free and happy. That will result in less clinical consultations and healthcare costs, and that will result in parents which are more settled and confident, and that will result in a happy healthcare provider. So functional gastrointestinal disorder or non-Ige mediated cosmic protein allergy, does it really matter as long as the symptoms are well managed? Because in a functional gastrointestinal disorder, the diagnosis is based on history and physical examination. But the same is true for non-Ige mediated cosmic protein allergy. And a challenge test will be positive both in non-Ige mediated allergy and in the functional gastrointestinal disorders. And the prognosis of both conditions is good, with the disappearance of symptoms and development of tolerance to cosmic protein at about the age of 1 year. So in the end, functional gastrointestinal disorders and non-Ige cosmic protein allergy are symptoms associated with the ingestion of cosmic protein. And with this last slide, I would like to thank you for your attention and try to answer your questions. Thank you very much for your attention.